Hello, friends. So let's talk about psychotherapy. Now, this is for those who are submitting their evidence under cohort 1A or 1B, because in 1A or 1B, you don't have to submit proper psychotherapy cases where you have done sessions with patients and that was supervised and you've completed a report. So you're not submitting the psychotherapy case. But what the expectation is that there has to be one case where you have made an appropriate referral for psychotherapy. Now, how can you demonstrate that? So if you look at when I looked into it, whether it is 1A or 1B, it is similar in both. So if you look at the HLO2, if you read upon, there's at least one case of the total 10 that demonstrates application of contemporary knowledge and principles of psychological therapies to make a suitable recommendation for psychotherapeutic psychological treatment. Okay, now this how can you demonstrate this? So the way you can do this is you are completing a case history in your 10 or 20 case histories. You are completing one case history where you have identified uh, some changes where you feel that the patient may benefit more from psychology, or the patient may benefit more from psychological therapy rather than pharmacological treatment. So how can you demonstrate that? It should start from your history. So when you're doing your history, you are identifying these patterns. So say for example, it's general adult, and if you're seeing somebody with recurrent self-harming behavior, what is the trigger? Is it the interpersonal personal relationship? Is it emotional dysregulation? Whether any previous psychological therapies were considered, or whether it was tried. So, say for example, you're seeing such a patient where with similar presentation, where you've tried all medications, it's not working, and there is severe, significant emotional dysregulation. Uh, uh, Patient was referred for cognitive behavioral therapy. Uh, Extensive sessions of CBT were done, but with little therapeutic benefit. There are some, one of the trigger is a relationship breakdown, whether it is family, whether it is partner. This patient also had interpersonal therapy but couldn't engage. But there is this recurrent pattern of self-harming behavior, uh, which is a big risk. And now you want to try something to mitigate these risks, and which may help in reducing such incidents and episodes. So maybe you have, maybe now you're thinking that maybe this patient is a good candidate for DBT, right? So so dialectical behavioral therapy uh, is something which we do consider. Now that is something, now you've established that maybe that would be potentially the therapy of choice or psychological modality of choice. Now, in your case history, you can mention that you've discussed with the patient and family, you've described about DBT in detail, about what dialectical behavioral therapy is, um, how it is done, what is the rationale behind that, um, what are the different ways, how many sessions, and there are, as you know, in DBT, there are regular check-ins as well. These things happen. So you're explaining that, you've explained it, and you when you so although you have explained that to the patient, but now it has to be in writing as well, because you have to submit this case history for your CESR, for your portfolio pathway. So you are explaining that in length about DBT And and then the family and the patient agrees to that. And then in your treatment plan, you have made that referral. And in that referral, what you can potentially do is maybe write a referral letter to the psychologist, or maybe in your treatment plan, you're explicitly mentioning that why are you referring the patient to DBT, right? Uh, and again, interestingly, the psychologist will also like that. Now, there is a reason why I'm saying this. When I started my CESR journey and I was looking for a psychotherapy case, my supervisor, I was having this discussion with my clinical supervisor. So the clinical supervisor suggested that, look, we've got a good case, and we think that psychology will help. So my consultant told me that, why don't you discuss this with our team psychologist? Maybe we can do CBT here. So, and I thought that maybe this is a good opportunity for me to do CBT. I met my team psychologist. I spoke to her, and I explained the case. Obviously, the psychologist knew about it because the psychologist was involved in the regular team meetings and ward rounds. And I requested that, is there a possibility where I can do the CBT under your supervision? So the first question which the psychologist asked me, why do you think that this patient requires CBT? Now, honestly, at that time, I was honest and I said that this is because my supervisor suggested. I've not thought about this, that which modality would be suitable. And then the psychologist, we talked about CBT, and we tried to establish whether CBT would be appropriate for this patient. And then whilst I was having the discussion with her, I realized that maybe CBT is not appropriate. I ended up doing cognitive analytical therapy with the patient. And there was a reason why cognitive analytical therapy was done. Because one of the common themes was that patient was very critical onto themselves. And cognitive analytical therapy is a good way to sequentially describe that in a diagrammatic way, and then which helps in understanding for the client as well to understand the pattern. And then we start working on it, and again, it's a long therapy. So I ended up doing 16 sessions of cognitive analytical therapy. So again, this is something you reflect on as well. So say you're doing a case history where you have clearly explained that this is an appropriate psychological modality of choice. But then you can add a reflection where you can mention in a reflection that you had a separate discussion with the psychologist as well, that what would be suitable, and you can explain, or you can capture that discussion in the form of a reflection, that what kind of discussion you had with the psychologist, and you can put that reflection along with the case history. So that is how you demonstrate. So what you can potentially do here is a case history where you are including the rationale behind the psychotherapy modality of choice at every stage of your case history. Then maybe you're potentially adding a referral letter as well, if you can, to the psychologist, that this is what I would like to do. And then you are adding a reflection of your discussion with the psychologist, that maybe initially you thought that maybe this modality would be appropriate, but then following your discussion with the psychologist, we came to the conclusion that no, I think this modality would be more appropriate for this patient. So you're adding that reflection. So case history, referral letter, and a reflection. So you've triangulated your evidence here. So this is one of the ways where you can demonstrate that under 1A or 1B. Now, the other thing to be mindful of is when it comes to old age psychiatry, obviously what I've mentioned in general adult, the same principle applies here. But again, in older adult, you also, let's take 1B here. Again, it's the same, whether it's 1A or 1B. But here in old age, you also, so as you can see, at least one case of the total 20 that demonstrates application of contemporary knowledge and principles of psychological therapies to make a suitable recommendation, right? In addition, at least one evidence of referral or participation on older adult specific interventions like cognitive stimulation therapy, right? So now again, this is something which has to be included in your cases where, and this is not that difficult. So say you are doing memory assessment clinics and you would have seen a patient and you would have potentially delivered a diagnosis to the patient and family, say Alzheimer's, for example. And then during that assessment, you're also providing post-diagnostic support. Whether it is during that assessment or in a follow-up assessment, you're providing post-diagnostic support. In post-diagnostic support, um, you discuss about the cognitive enhancers that is there, but then you're also talking about cognitive stimulating therapy. And that is something which is done in groups, which is also uh, facilitated by the nurse. If there is a psychologist in the team, it is obviously organized by them as well. There are many social groups where cognitive stimulating activities are done. So then again, in your clinic letter, in your memory assessment letter, to the GP, you've also mentioned that in your post-diagnostic support, you've discussed about cognitive stimulation and you have referred Mr. and Mr. or Mrs. to the cognitive stimulation therapy group where and then in that letter you mentioned that you've explained about what cognitive stimulation therapy is, why is it beneficial, and what kind of stimulating activities you do, whether it is reading, problem solving, learning new activities, or puzzles, or there plenty of activities happen. Maybe physical activity, a walk. So a lot of things happen in these cognitive stimulating activities in groups. But in your letter, you can clearly rationalize why you are referring the patient, you are explaining to the family, and you're talking about things in detail. And that has to be captured in your letter, in your case history. And then you're referring the patient to your neurocognitive psychologist who would then take over and start the cognitive stimulating therapy. So this is something you have to add in old age psychiatry. And I think this would be in addition to the other psychological modality as well. So I think this is something you need to add extra in old age psychiatry. So again, it is about doing that appropriate psychological therapy referral, but you need to be very clear on which modality and the rationale behind that modality. So I hope this was useful. I'll see you again in the next video. Take care. Bye-bye.